Welcome to another episode of the Empowered Fertility Podcast, the place where we dive deep into all things fertility. I'm Dr. Brenna Squires, a clinical psychologist and fertility support coach, here to bring you the knowledge, resources, and expert insights you need to feel confident along your journey to parenthood. So let's get started. Hey everyone, and thank you again for tuning in to another great episode of the Empowered Fertility Podcast. I'm your host, Dr. Brenna Squires, and today we're diving into how to speak to your doctor when you first decide you want to grow your family. Most couples see their primary care physician before they see any other professional, before they see a fertility specialist. But most of the time you hear, what do I expect from this appointment? What questions should I be asking? And what should I be doing early on to make sure that I get the right support? And today we're answering all of those questions because I'm joined by primary care physician, Dr. Amita Kumar, to walk us through what patients can expect and how best to advocate for themselves in these conversations. So welcome, Dr. Amita.
Hey, thank you for having me.
I am so glad you're here today because I'm really interested in hearing your perspective and what you have to say, because you really are most people's first stop on this journey. But before we jump into that, I would love for you to share a little bit about your practice. And as a primary care physician, you see a wide range of patients. So what does fertility preconception health usually look like when it first comes up on a day-to-day basis?
Yeah, I am practicing in San Antonio, Texas. I actually did my residency in Kentucky and my medical school training in Dublin, Ireland, but I grew up in Canada. So I've had several different perspectives of different kinds of patients and what different cultures and different patients, and also just like my own sort of growth through the process has really the light shown on it. So depending on the day, I guess we'll say, I do get different kinds of questions. So I probably get questions like, what should I do if I'm thinking about getting pregnant? All the way to, I've been trying to get pregnant and we haven't been able to conceive. All the way to like, what kind of birth control should I be taking in case I want to get pregnant, in the future. And so, I don't know, where do you want to start?
Yeah, well, let's start at the very beginning. So
Okay,
let's say the person books their first appointment and they come in and it ends up being about fertility. What
sure.
are some common reasons that actually bring them in? Do they come in because they want to talk about fertility? Or is it something else that brings them in and they just casually ask about fertility?
No, many times it's specifically that.
Okay.
Usually if a woman comes in with her partner or husband, and the husband or partner doesn't have an appointment, it's about something like that. Because otherwise, women pretty much come by themselves. Men don't come by themselves as often, so it's different if he has an appointment. But if only she has an appointment, it's sometimes and if they're relatively young, that's usually the case. And honestly, sometimes it's just something simple like we're thinking about having a baby at some point, like in the near future. What should I do? So the advice is, something simple like start some prenatals, and we got go through just like a general nutrition and bad habits discussion. Like not because of judgment, just because it's good to know what we're dealing with. If are we dealing with alcohol, caffeine, smoking, drugs, whatever, right? Like all of that is fair game when you come to the doctor. And it's really important to bring it up because if you don't bring it up and then something happens congenitally, with the baby, then that's like a whole nother ballgame. But if we're sort of thinking about it ahead of time, anything from like blood pressure issues to small babies to preemies, all that stuff, right? So it's just good to like be upfront and open, and your doctor is not going to judge you. This is really just to get a good idea of what's going on. Also family history, family history of diabetes, family history of difficult pregnancies, family history of autoimmune diseases or clotting disorders, and then of course your own personal history of, pregnancies or time you've been trying, etc. And I guess I should probably clarify that on more than one occasion, I have discussed what trying means. So, that some people may be surprised to hear that every other day intercourse for like 6 months to a year is essentially trying. The few times I've said that, the husband in the corner is like, you know, and the woman is like, "Oh," you know? So, but that's really what it might take. So, that doesn't mean it always takes that, so just, be prepared. Sometimes it only takes one time. But, sometimes they've been trying, sometimes they haven't, and it just kinda varies.
Yeah, that's interesting. I like how you were saying that how much it varies with some people will come in where they've already started trying and they just kind of know what next steps they can take. But it sounds like some people are just planning really far ahead and they're saying,
Yeah.
I want to get pregnant sometime in the future and I want to know what to do. Do you see that those people may have had either preconceptions or problems in their past and that's why they're trying to plan ahead?
Sometimes, I mean, I think that a common one well, I think that many times that person has some sort of fear about something, whether
Okay.
they've heard their friends having trouble getting pregnant or their mom, or they've read something, or they've been on birth control for a long time, and there's this, you know, misconception that if you've been on birth control, then you have to go off of it for X amount of time before you can get pregnant. That is not true. You can so if you want to get pregnant, be ready to get pregnant if you get off your birth control.
Hmm.
Um, you know, but also like things like PCOS or diabetes or even just being overweight or sometimes it'll be that they have a history of drug abuse or drug addiction. I mean, they may not, be doing that now, but they're concerned about something or they have some anxiety about something that is bringing them in to say, "Hey, I'm a little worried that my history of whatever um, might prevent me from getting pregnant in the future." But I gotta say that many times it depends on the situation, but many times it's not even the history of something that might prevent somebody from getting pregnant, but rather just the thought of worrying about. Um, we all hear about stress and all of its ripple effect, and I know we can't measure stress per se, but just the tiniest inkling of that, like I'm stressed about something, that in itself could prevent you from getting pregnant.
Yeah, that's very interesting to hear because I like how you said it's not always just like the history because history does play a role. But if they were told younger that they couldn't get pregnant or they would struggle to get pregnant, or that it would be easy for them to get pregnant and then they're not getting pregnant,
Yes.
all of those things play a role in their thoughts. And again, coming to you automatically with fear.
Yes, yes. Like they usually come with some worry. Um, you know, it's rare that I have patients that come in because they're healthy. Or like meaning they're healthy on paper, but they're like, everything's good. I just need some labs. Um, they sometimes start that way and say, like, I'm healthy, I just need some labs. But it's oftentimes that like as we talk more and more, some sort of fear comes up
Yeah.
about something or other. Whether it's just because they had irregular periods as a kid or painful periods, or their mom had endometriosis or fibroids or PCOS. Those are probably top 3, diagnoses that women have as far as like abnormal periods go. Um, so those are top 3 diagnoses that people will bring up, even if it's not in themselves. Like my sister had X, Y, and Z, or my mom had X, Y, and Z. Therefore, I'm worried about myself because of, ABC.
Yeah, and so with that, it sounds like they come with some things that they're already fearful for, but they may forget to prepare in other ways. So, what are some good questions that patients can bring up to their primary care to make sure that they're getting the most out of this appointment?
Yeah, I mean it's relatively simple. Like I think definitely we go over a lot of things. Just oftentimes we will do some blood work, simple things like thyroid, glucose, that cholesterol, because it's there and it's a good screening test. And usually it's mostly reassurance. Sure, if there's a thyroid abnormality and we fix it, be prepared to get pregnant, you know? Um, but sometimes things like PCOS are not so simple. But I can tell you, and I'm sure you would agree, that there are many people who probably don't have a diagnosis of PCOS that probably have PCOS, or vice versa, that have a diagnosis of PCOS but have never had any trouble getting pregnant. So just conversations around that, I think, and that Fortunately and unfortunately, fertility is still a bit of a mystery oftentimes.
Yeah.
Um, you know, sometimes we can pinpoint something and we will optimize that scenario. And like I said, if sometimes it's like a small thyroid abnormality, we fix it, the best case scenario, and you get pregnant like immediately, you know. But sometimes we literally find nothing wrong, and of course I'll refer to the OB-GYN or the fertility specialist, and we'll cross that bridge. But having someone on your side, having a primary care doctor who's also there to be like, okay, well, how much of this is infertility versus worry about infertility might be an interesting, crossroads.
Yeah. And at what point, that's a good question because at what point do you refer them to like a therapist or a psychologist or someone to work on those worry thoughts as opposed to diving deep into the other things?
Um,
Or do you refer
eventually,
to both?
yeah, I mean both, but like I was just thinking about this morning. Like, I think I've had pretty good luck with most of my patients. I'm not sure that I've given them some crazy advice. I mean, it's literally this advice, but I think that the reassurance that they have a doctor on their side, a doctor they can turn to, a doctor to ask questions. Sometimes they'll even say like, "This is a dumb question," and I'm like, "Oh man." Oh, that in itself makes you feel as a patient,
Mhm. Yeah.
insecure. So for me to just help them feel like it's not a dumb question, it's nothing to be, embarrassed about or worried about until further notice. Sometimes that in itself is just reassurance and helps them get to the next step. Of course, I have some patients that have sought out infertility specialists. I think if you end up, doing what you're supposed to do, we'll say, quote unquote, um, and you are having trouble getting pregnant, and then, we discuss possible infertility specialists. I think anxiety comes along with it, if it wasn't already there. And so definitely we talk about, therapy and maybe even anxiety medications. Um, and that too has its own misconceptions because sometimes I have patients that are on anxiety medications or depression medications, and they're worried about continuing them in case they get pregnant. And so we have that whole discussion about what's what's safest for the mom is safest for the baby. Depending on the exact medication.
Yeah. So it sounds like what we would like all primary carers to do is you validate their concerns, you address their concerns with facts, and you take away you do some of that cognitive,
Yeah.
almost like cognitive behavioral, so to speak, of just
Yeah,
taking away
yeah.
some of their maladaptive thoughts and just say, hey, that's not true. This is true.
Yes,
And
yes.
for many people, even just simply doing that early on can mitigate the need for any other treatment later on because I think,
Agreed.
like you said, some of the fears build up because they're not validated, because they're not challenged, because they're not addressed. It's just, okay, nice, let's keep going. And they kind of feel like they're being dismissed. And so I like to hear that you just address them straight on. So it kind of reduces the need for that extra step
Yeah,
early on.
that's the ideal scenario. It depends on how much time they've spent, Googling usually. Um, but I think that most people now, know. I think, even if most people that have been Googling will come in and be like, "Okay, so this is what I read, and I know that not everything on the internet is true." So, they already know, now I'm anxious about stuff I read. So I need you to tell me what's true, what's not true. So that's also really helpful because when you come into your doctor and are aware of the
Mhm.
fact that you've been reading because you were worried, but now you need an expert opinion, that's helpful. And of
Mhm.
course, now we have ChatGPT, which again is actually a great
Yeah.
resource with a grain of salt, like anything else. So I don't think there's anything wrong with starting, like one night at 9 p.m. when you can't sleep or midnight when you can't sleep and being like, what if I can't get pregnant? But I'm sure that most people, and in fact, most of my patients tell me, once I started doing that, everything results in cancer or death. you know, as you know, as soon as you go down the internet rabbit hole, those are the two options. And so they come to me and they're like, okay, I need your help now. And so, it's relatively easy and maybe I've just gotten lucky. And And I do try to be as approachable and open as I can. And it's relatively at this point in my career, I can be like, I think you're okay. And if you're not okay, we're going to address that too. And maybe that's part of it, right? Like you're here now.
Yeah, what you said that some people come in with either dumb questions or they'll come in and just want, okay, what's the truth and what's not the truth? What are some of the most common things that you hear that you have to just set the record straight?
um, oh, okay. I mean, man, it really varies. Let's see. One is probably, oh, I'm overweight. I think that's a common one. Because I'm overweight, I heard that it might be hard for me to get pregnant. I'm like, I mean, who knows? Like that's a good and then usually the next question is from me is like, well, are you having periods? And if you are, then you're ovulating. I mean, that's it. If you're having periods, you are ovulating. I mean, there are some rare cases where that's not the case, but most of the time, if you're between age 15 and 40 and you're having periods, you're ovulating. Um, Now, if you're not, then we will address that. And when I said dumb questions, that's not me thinking that they have dumb questions. They come in and say, "Hey, I have this, quote unquote question. I don't know who to ask, or I don't feel comfortable asking anyone else. Or when I asked my friends, I got an array of questions. Or when I asked ChatGPT, I got an answer I didn't like, or whatever." But no, there's no such thing as a dumb question. Literally, I had, like a 38-year-old woman with a history of pre-diabetes. So that's a common question. She's a little bit overweight. And she was just so worried that she wasn't going to be able to get pregnant. And literally all I said was, okay, well, I think you should just try to start having intercourse every other day and let's just reassess. And not even 3 months later, she was in my office, like giving me this big hug. And I'm like, I don't know what happened, you know? But so it can be literally as simple as that. But I think the biggest thing I've noticed is helping people, just reassuring people that they're on the right track. They've done nothing wrong. Nothing in their past is unlikely going to prevent them from getting pregnant. That they have done themselves, I guess, is the point.
Yeah, and that brings up that whole, um, again, bring all of your questions and even the questions that are unprepared, but bring
Yeah,
all of that information and then you can have something to work with.
yeah, yeah.
And with that, that makes me think though, like there's some things though that I feel like you probably need to prepare for, like you may not have known. Like let's say, um, I'm trying to think like, is there a history of like an infertility in your family, or is there a history of heart disease in your family, or things like that? Is that something that somebody should know, or it doesn't matter if they don't know some of those things?
I mean, in my office, it probably doesn't matter as much. I mean, I had a couple the other day where they had a son who was born with a congenital abnormality, and they came in. Their son is now like 8, and they were of course extremely nervous. And they were like, we're afraid to have another baby because we know that our first one had this congenital abnormality. Now he's okay. It was hearing loss or something that they were able to fix, thank goodness, with amazing technology these days. And but they of course were very reluctant and scared. And part of it was like, okay, well, let's start looking through the genetic things. Let's look up the paperwork from your old genetic testing. Let's meet with an infertility specialist, but rather in that case, it's actually not infertility specialist, more like genetic specialist, right? Like we don't want to go to necessarily infertility specialist right away, but maybe we need to figure out how we can prevent this abnormality from happening again. Or is this really just like a 1 in a million chance and it's probably not going to happen again, depending on what the situation is. Your menstrual cycle history is probably the most important thing. Are they regular? And then of course, like your mom's history, um, you know, and then of course personal history of whether you've had miscarriages or not, or previous pregnancies.
Yeah. Have you ever had anybody come in that said they didn't really track their periods, so they don't really know how frequent or not frequent, or how much they bleed or don't bleed, things like that?
If we're talking about fertility, then no. If we bring up pregnancy, women are all over I have been having this many periods and this is what it's like. And especially nowadays with the apps and stuff, you know. Most women know if they have regular or irregular periods. Um, you know, how regular or how irregular, that's different. You know, like teenagers sometimes don't realize that, you know, a period every 3 months is not exactly normal, but it's not that abnormal for a teenager either, right? Like, depending on what's going on. They're in sports and they're stressed and whatever. But for mid-20s, 30s, those women know. You know, they've had periods for 10 to 20 years and they're like, "No, I know my period history."
Yeah. And so, realistically, what can a primary care physician do in terms of fertility support before referring to like a fertility specialist or OBGYN?
Looking for insulin resistance and thyroid as far as blood work goes, and then, of course, like, you know, glucose and diabetes or prediabetes if the patient doesn't already know those things. And then, of course, just support as far as discussing prenatals, whether or not they need regular amount of folic acid or a higher amount of folic acid, again, based on family history. Um, and then, you know, just nutrition, exercise, and what I always say is everything in moderation.
And you've mentioned that a couple of times with like nutrition and exercise. From your perspective, how do lifestyle factors like these things fit in and how do they impact fertility as a whole?
Okay, so I'm not sure that I know the exact scientific reasons, but I would say anecdotally speaking, it's because you're just taking care of your holistic health. You know, when you're taking care of your physical health and your mental health, then your body is probably ready to conceive. Um, you know, does it always happen that easily? Of course not. You know, but when you're worried about things and you are letting things slip because that's just, you know, what humans do, then it's more difficult to conceive because I mean, call me, I don't know, spiritual or woo woo or whatever. I'm not really, but I can't stress enough how much nutrition and just healthy living. I'm not saying you need to be, you know, fit and going to the gym 5 days a week and eating no carbs and eating a salad every day. That's not what I'm saying. What I'm saying is just being mindful of eating nutritious food. Probably my newest favorite mantra is that food is fuel, right? So, um, I am not a huge proponent of vitamins, for example. Obviously, if you're deficient in something, I think you should supplement your life and diet with vitamins, like vitamin D and B12 are most common, probably. But I don't want people to take vitamins instead of eating nutritious food. So I think that's really my thing, especially in this day and age with protein shakes and protein coffees and protein powders. I don't know. I'm not anti anything. I'm just saying if you're having a protein shake, that's fine, but you still need to eat real food.
Yeah. And with that, I curious of your thoughts of when you say eating food, good food, what are you advising your patients as good food? Are you saying um like keto, paleo, carnivore specific diets, or you giving like specific ideas, or what are you kind of advising for that?
I mean, I kind of half joke that everyone already knows what they're supposed to eat because in kindergarten we get the food pyramid. Um, you know, so half your plate should be veggies and, you know, greens. One quarter should be protein and one quarter should be carbs. Now, you know, in Texas we have really big plates, so maybe not the giant plate half,
Not the plate.
not the large plate, but maybe the like medium plate. Um, but that's kind of what I suggest. And I think the other thing is um I'm also a health coach, a life coach certified. In my health coaching, the big thing is listen to your body because I think that when you deprive yourself of something, you just end up binging on it a few days later. For anyone that has been zero carb, I know you know what I'm talking about. Um, I'm not saying you can't do it for a couple of days, but when you're trying to get pregnant,
Yeah.
everything in moderation.
Yeah. What about the people who say, my body is telling me I need chocolate cake?
Your body might be telling you it needs chocolate cake, but the question is why? Is it because it needs sugar because it feels bad about itself? Is it looking for a dopamine hit? Is it trying to make you feel better because you're premenstrual. I mean, all of that is not wrong. But it's like, why is your body saying it needs? Because my body tells me it needs chocolate the week before my period too, because I need dopamine. Like, and there's a reason. So
Mm,
don't beat yourself up about what your body is saying it needs, but just think about like, why is it saying this? Or is it because I drink 3 Dr. Peppers a day and the more sugar I drink, the more sugar I want?
hmm. I like that. I like that idea of not beating yourself up over it and not completely denying it, but more taking a curious perspective of saying, why am I doing this to understand a little bit better? Because from my understanding, it sounds like similar. If it's certain during a certain time and you're craving chocolate cake and you're having like a small piece, or it's because of, like you said, your period and you're craving that dopamine hit, or you're needing something sweet small. Is that okay to do in
Of
moderation?
course. Of course. I
Because
will
I feel like
never
that would
tell
reduce
anyone.
stress.
Well, I will never tell anyone not to eat chocolate cake or pizza. That's like just now most recently I'll never tell you not to eat salt and vinegar chips. Though that's my, that's my thing and I know that that's my thing, so I know that it can get away from me. For example, and again, I know we're not talking about specifically diets, but I think this is important because I think as women, we we really focus a lot on what we're eating.
Mhm.
And when we're, I mean, I use the term obsessing, but lightly, like when we're thinking about food all the time and we
Yeah.
have this constant food noise even,
Mm.
it doesn't feel good.
No.
And it doesn't make you like yourself more. You know? And when you don't like yourself, then you start stressing and then you want more of that dopamine hit.
Yeah.
Whether it's chocolate or Instagram, both
Mm.
of those things give you a dopamine hit, but they don't make you feel good about yourself. So I think the key is like, I mean, even before our call today, I was like, I'm going to go and get some sunshine. It is a beautiful day in Texas. It is no longer 100 degrees at 8 a.m. you know? Uh, so I'm like, I'm going to go for a quick 15-minute walk. And like, even just a 15-minute walk in my pretty urban neighborhood, it's not that full of nature, it is really refreshing. And I feel good about myself for doing that.
That's interesting, and I like how you were saying with that the food noise, and it's so true that we can have this food noise of this pressure that we put on ourselves because we can't eat that or can't do that, and it's making things worse. So I like the idea of asking, well, why do I need that? And I like the replacement as well. If you're feeling like, okay, you just need that dopamine hit. Okay, well, there's other things you can do, like let's go for a walk, and it might have a similar effect. I mean, it's not chocolate cake, but you might crave the chocolate cake less after a 15-minute walk.
Yeah. I mean, it's easier said than done. I get it.
Yeah. Yeah, sometimes it
But
is, again, going back to why you're doing that, and I like how you also said, does it make you feel good about yourself at the end of the day?
my patients will tell you that I say, I'd rather that you feel your feelings than eat your feelings. The more you think about it, the more you're like, ooh. Yeah.
It is, ooh, and I've actually had several clients this week talking about that because feeling your feelings is hard. It's
Yeah, yeah,
really
yeah.
hard, but when you do, you're able to get to these questions, like you said, "Well, why am I doing this?" And then that allows you to be, more in tune with your body, and then it makes you like yourself a little bit more because you figure out the reason why, and now you have more self-control over, "Do I actually want the cake or do I want the effects of the cake?"
Exactly.
That's
Feeling
that's
your
so
feelings is
interesting.
tough. There's no doubt about it. And it is not
Yeah.
usually fun.
It's
But
not. You're not enjoying the food
yeah,
most of the time, but at least the longer you're doing it, what
right.
I've found.
And then of course we all know that once you eat all that stuff or you binge on something, then you're like, oh, now I feel bad that I binged on something. Um, I know we're digressing, but I actually think it's really important in women's health to talk about this.
It is really important because they might not be sharing these things with you at the primary care office. They might just kind of be saying, "I kind of feel like this, but I don't know. I don't wanna say that." Like, this is
Right.
the dumb question slash, "I'm not talking about this" thing.
Right. Right. Yeah. And, as we all know, right now, mental health is really
Mhm.
crucial and mental
Yeah,
illness is on the rise.
yeah.
Um, in young people, in older people, the work from home, the not work from home, all of this stuff. So it's been a rough 5 or so years for young people and working people alike, but not addressing it just makes it worse.
Yes. And with that, let's say somebody has kind of, let's go full circle a little bit and say someone's addressed it as best as they possibly can. They've tried some different things and they've come full circle and they're like, "Listen, I've gone to different specialists. I don't know what else to do. I'm back in your office and I still can't get pregnant.
Sure.
Now what?"
Then then we refer to fertility. I mean, then we refer to OB and see what the next step is, right? Like, um, I don't like jumping straight to MFM or infertility specialists because they often get self referrals, but they are better served if you get a referral from your OB or your gynecologist, because the OB-GYN can look for most common things. At the end of the day, we're doctors, but we're still human. And so when somebody is a super specialized person, they're so used to looking at like infertility period that they may just jump straight into like, okay, you're not able to get pregnant. I'm going to help you have a baby, right? Like,
Yeah.
and that, of course, that's why you're there to get them to help you have a baby. But maybe it's something that the OB-GYN could actually help you with. Like, is it something that they need to just help you regulate your periods, or they need to help you with your PCOS, or they need to help you um with, some scar tissue or whatever. Like, it just depends on something. So I would say going to your PCP, then going to OB-GYN, then going to the infertility specialist is the ideal stepwise approach. I know that it takes a bit of patience, and I think that's probably the hardest part. Um, but I think that's where all the like mindset work comes in, because the more impatient you are, the more anxious you get, the more stress you endure, and then the less likely you are to conceive. you know? So it's sort of this vicious cycle if we don't get some validation and reassurance along the way.
Is there anybody that you ever you see their history and you kind of have them like skip the line, so to speak, where you don't need to go to the OBG, you can go here?
I
Like, do you need to go to the fertility specialist immediately, or is there any time somebody needs can you see like they can skip the line?
think that nowadays patients have probably pretty much decided on their own, and I wouldn't necessarily deter them from that. If it's been, 6 to 12 months of them trying and we've already had some conversations, um and also if they've had several miscarriages, things like that might be indicative of going straight to the infertility specialist. I also know that a lot of infertility specialists don't take insurance, so I like to be mindful of that. And I want to be really transparent and open with my patient, because at the end of the day, well, they're going to go to the infertility specialist, they're going to go to the OB-GYN, but they're going to be my patient for the next 40 years, So so it's really important for us to have all the conversations, even if they're difficult.
Yeah, and with all of those conversations, is there anything that you can't do as a primary care? Like, you can't
What do you mean?
prescribe this or you can't,
Oh,
recommend this certain
I
things?
don't prescribe like clomiphene. That's like the Clomid. It's to stimulate egg production or egg dropping and stuff. I'm not sure if there are primary care doctors that do that, but I don't, and I really haven't been trained in that, so I just don't. I have prescribed metformin. I have prescribed thyroid medicine. I've prescribed different hormonal things for, starting your period or stopping your period or things like that. What else? I mean, I don't do any like procedures. So if we are concerned about endometriosis, but I can definitely send for like ultrasound or, um, of course, tons of lab work. I'm thinking, of course, hormone panels are all in the lab work. Uh, I don't know. That's a good question. I mean, I'm sure there's things I can and can't do, but it kind of just depends on what the patient is looking for and their expectations. There's so many levels and nuances. But like I said, I think that many times if they're coming to me, because these days most people can actually self-refer to an OB-GYN, but if they're in my office, it's usually because they've Googled something and they're afraid of something. And many times our conversation is around reassurance to begin with.
That's a really good, point that you're making, that for that first stop, it's true, it's really for this extra guidance and reassurance that you need of where can I go
Yes.
aside from what Google's already told me.
Yeah, 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 exactly, exactly. Because there's so much information already out there. Um, you know, if you put in all your symptoms in ChatGPT, it'll tell you you need to see a gynecologist, or it'll say, I don't know what it'll say, but it might say like this could be a thyroid issue. Some people will come in and say, I think I have a thyroid issue. Or this sounds like you have PCOS. You should see your primary care doctor or an OB-GYN. And sometimes they can't get into the OB-GYN, so they'll come to me first, or maybe they need a referral for OB-GYN. And some people will just come in and say, I'm not here to ask you anything. I just only need a referral to OB-GYN. But because they're there and because they're my patient now, we have open discussions, and sometimes they'll actually really learn something, or we can start the ball rolling. Why wait 6 weeks to do some basic blood work if we can do it now?
It's cool. That was gonna be my next question. What do you do with those people who just kind of come in for a referral, and you said like you might just ask to start the blood work to get the ball rolling?
Yeah, that's an
Kind of,
easy place to
you
start,
said blood work of thyroid, cholesterol,
hormones,
and like A1C or something
A1C, and
else,
then hormones usually. Yeah.
hormones.
Yeah,
Okay,
and then
cool.
depending on what's going on, if we need to get an ultrasound, we can, but, it just kinda depends on where they are in their journey and how anxious they are. If they're not really, then I usually say, "Just wait till you go to OB-GYN because they're gonna poke you regardless." So, um, it just kinda depends. Sometimes doing the lab work in our office, I usually get the blood work back, within 5 or 7 days, and being like, "Okay, everything is actually normal on your blood work, or this particular thing is abnormal on your blood work." Even if it's abnormal, it helps bring that anxiety level down.
Yeah, because there's an answer. Do you say anything different to people who come in that are let's say women who come in that are in their 40s?
Probably. Let me think. Um, it doesn't happen that often. I think most women who are in their 40s know that their risk is higher. Um, Thanks to the ICD-10 codes, I believe that after 40, unfortunately, we're described as geriatric. And so
We need a new name for that.
kind of painful. Uh, so, it is what it is. It's
Mm,
it's not meant to be judgmental. But it is more difficult to get pregnant, and I think most women at 40 know that, right? If they didn't know it before they Googled it, they know it after they Googled it. And sometimes they do come in kind of panicky. But again, I like to have really honest and open discussions. Of course, it's not impossible to conceive and have a normal child, right? But is it going to be more difficult? Possibly. And again, like any illness or disease or whatever, like books say one thing, but humans do another. So until you kind of start trying and start discussing, and we just do it the safest way possible and the healthiest way possible, we don't really know.
yeah, it got me thinking too with at what point do you say, "Hey, what about the man? Has he had anything checked?" Or
Yes,
maybe
yes, yes.
he should have something checked.
So if the patient comes in and says, "Hey, we've been trying for a year or 6 months, and we have been having intercourse every other day, and it's not working, and I'm having regular periods, and I've had no issues." Then I might send them directly to the infertility specialist, and I'll of course tell my patient, well, it's not all on you, you know, because the infertility specialist will first things first talk to both people and test both people. And commonly it is the man. And just depending on what it is, if it's an infection or if it's immotile sperm or whatever. Like if it's a sperm issue, then they address that. But yeah, I think that's a really good point. And I'm sorry I didn't bring that up earlier. I guess I just have a lot more female patients that come to talk to me about it than male patients. Um, and male patients don't have any like indication usually, right? That they are
Yeah.
having like a possible potential trouble. Women, we have our, menstrual cycle, and whether it's 1 month it's different than the other month, and you're like, "Oh, no." Like,
We have
so
plenty
we
of
just
signs.
yeah, we have a million signs that could or couldn't mean something. Um, and so I think that's why I often see those patients, and not the men, but of course, infertility can be, the male for sure.
Yeah, so it sounds like, if they've been trying for a while and still nothing's working, like you said, 6 months, or if there's been a history of a miscarriage or something like that, then you
Yeah,
might just jump to say, "Hey, we need
sure.
the man checked as well."
Yeah. Well, if there's a miscarriage, then they are able to get pregnant. So it's
Okay, it's a little
it's
different.
unlikely to be a sperm issue, because if you are not getting pregnant, then it's probably a sperm issue. But if you are able to get pregnant, then it's unlikely to be a sperm issue.
Okay. Okay. And as we kind of come to a close, what final thoughts do you have for someone who's a little bit nervous about making this first appointment, or they've had an appointment, but they feel like they want to go to another primary care physician? What would you say to encourage them?
Um, I think that the first thing is, I think doctors are like hairdressers. Okay. My hairdresser might not work for you. So, like you may love her and she is great with long curly hair, but I have straight, like short hair. And so this is not the right person for me. And I want everyone to really feel open to like read about your doctor, or like I know these days with certain kinds of HMOs and certain plans, you only have a certain amount of doctors you can look up. But if you think you want a female doctor, then just stand your ground and find a female primary care doctor. And read about her a little bit and see if you think that you might be a fit, and go in, I think, with an open mind, and try to have a discussion. Like, I think most doctors these days are a lot like I am, which is we know you have all the Googleable information. And that's not a bad thing, but I hope that most of my patients now also know that Google comes with a grain of salt. Try not to get worked up about the stuff you read on Google. But we're also here to talk through it with you.
Wonderful. Thank you. I really like that encouragement of self-advocacy to find the doctor that you fit best with, because they are the point person, so to speak, on this
Yeah,
journey, and they
yeah,
can be really supportive
yeah.
during this time. Awesome. Well, thank you so much. I really appreciate you taking the time to speak with us today and sharing your wisdom.
Thank you so much. It was fun.
And thank you so much, listeners. I hope you really enjoyed this episode. If you found this helpful, share it with a friend who's also navigating fertility. And don't forget to subscribe so you never miss a conversation that could empower your journey to parenthood. Until next time, take care and stay hopeful. Thank you so much for joining me today on the Empowered Fertility Podcast. If you're looking for personalized support on your journey, whether that's through therapy or coaching, please reach out. Just complete the contact form linked in the show notes, and someone from my team will be in touch with next steps. Remember, you are not alone. You are not broken, and your story is not over. See you in the next episode.